Hi guys, today we will be discussing a very common disease presenting in dermatology OPD, that is WARTS. As we all know, the causative organism is human papilloma virus or HPV, which is a non-enveloped double-stranded DNA virus. The pathogenesis involves infection of basal keratinocytes. As virus divides only in fully differentiated squamous epithelia, whenever there is minor skin trauma or abrasion, virus directly enters to basal epithelial cells and induces their hyperproliferation, leading to formation of warts. As we can see in this picture, this is stratum basal, stratum spinosum, stratum granulosum and stratum corneum. Normally the basal cell layer is not accessible to virus due to these all overlying differentiated cell layers. Virus enters through the stratum corneum, uncoats itself and leads further causes infection of stratum granulosal layer where virion assembly is occurs and there is formation of cholocytes. We will discuss about cholocytes in histopath. Then virus then proceeds to stratum spinosal layer and causes hyperproliferation of spinous cell layer leading to formation of acanthosis. Then virus enters the basal cell layer where less than 10 copies are present per cell. As virus will start replicating in basal cell layer, it will lead to its hyperproliferation. Whenever there is skin breach or skin trauma, virus directly go to basal cell layer and induces its hyperproliferation. The two major genes involved in its pathogenesis are E6 and E7. What we have to remember is E6 binds to tumor suppressor gene P53 and E7 binds to retinoblastoma gene. As we all know, these both are tumor suppressor gene. Once these tumor suppressor genes are suppressed by E6 and E7, that will induce hyperproliferation of the cells. The inhibition of cell cycle has been overtaken and this will lead to hyperproliferation. First we will discuss about the clinical presentation of the disease. There is two types of clinical presentation: cutaneous infection and mucosal infections. The most common cutaneous infection that we see in day-to-day practice is verruca vulgaris. Also known as common warts. As in picture, how to identify verruca vulgaris? These are hyperkeratotic, exophytic, dome-shaped papules, or they can form plaques. Similar, in the second picture we are seeing verrucae palmaris et plantaris. These are palmar or plantar warts. These also have similar presentation. These are hyperkeratotic, exophytic, dome-shaped, can lead to formation of papules or plaques. Third picture we can see verrucae plana, also known as flat warts. As you can see in this picture, these are skin or pink to brown colored, slightly elevated, and most distinguishing feature, that is flat topped papules. The most important question that we and generally ask the strain generally causing these infections are 1, 2, 4, 27 and 57. Other rare cutaneous presentation is epidermodysplasia verruciformis. As we can see in this picture, these are generally polymorphic lesions we can't classify whether this will form papule, macule, plaque. These are polymorphic lesions which can be discrete or confluent, generally scaly, pinkish or hypopigmented macules, as you can see in this picture, which might resemble pea versicolor. Then fifth variant is epidermal dysplasia verruciformis induced squamous cell carcinoma. The strains responsible for these are 3, 5, 8 and for squamous cell carcinoma 5 and 8. Second presentation is mucosal infections. Mucosal infections can be classified based upon the strain. Benign infections are generally caused by 6 and 11, and malignant changes are induced by 16, 18, 31, 33, 45, 52, 58 and so on. Here, first picture that we can see is condylomata acuminata, a very common mucosal infection that we see in dermatology OPD. Location is mainly on external genitalia and perineum, also known as anogenital warts, and these are discrete, sessile, skin or brown or even white colored due to maceration in the area. Exophytic papillomas. Here in a female we can see a broad-based condyloma acuminata of brown color, broad-based condylomata acuminata. Other type of mucosal infections are condylomata plana, bovinoid papillosis, erythroplasia of Curette. As in this picture we can see erythroplasia of Curette, very well demarcated velvety plaque present over papules. These all are high grade intraepithelial lesions. The strains basically responsible for condyloma acuminata are 6 and 11. For these type of lesions, generally 16 and 18, 31, 33, 45, 52, all the oncogenic strains. Another uncommon presentations, mucosal presentations of anogenital warts is Buschke-Lowenstein tumor, also known as giant condylomata acuminata, which is caused by 6 and 11. Condylomata acuminata. Laryngeal papillomatosis, also known as recurrent respiratory papillomatosis, again caused by strain 6 and 11. Child generally presents with hoarseness, stridor and respiratory distress. Then Hex disease, which is mainly a focal intraepithelial hyperplasia caused by strain 6 and 11. Lesions are mainly seen on gingival, buccal or labial mucosa. Now we will discuss the histopathology. As we can see in this picture, there is generalized hyperproliferation of all the skin layers. The distinguishing findings are hyperkeratosis and Papillomatous acanthosis. As we can see in this picture, there is very hyperkeratotic skin layer, stratum corneum, and there is this, if you can distinguish, this is papillomatous acanthosis. In the second picture, we can see these cells. These are very characteristic finding in warts. These are coilocytes. Coilocytes are very diagnostic of HPV infection. Coilocytes and keratohyalin granules. These two findings are characteristic of HPV infection. Discussing about coilocytes, how will you identify? These cells have clear cytoplasm and a central hyperchromatic nucleus, hyperchromatic enlarged nucleus. Keratohyalin granules, these are eosinophilic inclusions in the cytoplasm, which represent virus particles, virion particles. So this is histopathology. Then coming to treatment of the warts. Treatment varies according to the location of warts. See, it is different in anogenital warts and cutaneous warts. The treatment of choice is mainly cryotherapy. As we all know, but cryotherapy is not feasible in every patient, and it is mainly an OPD based procedure. So we have other therapies like application of podophyllin. If it's OPD based, we apply in our OPD 20%, and if it is patient based, we give them 0.5% BD application for 3 times per week. Another very popular therapy, that is imiquimod 5%, that is also patient based. It is mainly an HS application. Patient has to apply it overnight, wash in the morning, and apply 3 times per week, every alternate night. Other available therapies are application of liquid nitrogen, TCA application, TCA 80 to 90%, that is again an OPD based procedure, or we can go for removal by shave excision, curettage, electrosurgery, or laser vaporization. See, all these procedures are very painful for the patient sometimes, so we have to do these procedures under anesthesia. Plus laser, this has side effects since it releases vapors, so these vapors can be infectious also. Then cutaneous warts. For cutaneous warts, treatment depends upon whether there is single or very few warts, or whether there are multiple warts, and if these are recalcitrant warts. If there is single or few warts, we can go for cryo, we can go for electrocautery plus curettage, or we can go for application of cantharidin. For multiple warts, we can go for cryo, we can go for intralesional immunotherapy. In this, we can use intralesional injection of candida or any dermatophyte fungus, trichophyton, or DPCP 2% intralesionally. For recalcitrant warts, we have 2 types of therapy. Either they can be patient based, like application of topical cidofovir, which is an antiviral drug, or oral retinoids. For OPD based treatment, we can go for intralesional cidofovir, intralesional 5-fluorouracil, intralesional bleomycin, photodynamic therapy, local hyperthermia. These are the various modalities. For patient based, we can give them topical 5-fluorouracil as well. Now coming to special situations like in pregnancy. The most commonly asked question, what are the treatment options in pregnancy? We can go for TCA application 80 to 90%, or we can go for cryotherapy. These both procedures are very safe in pregnancy. So this is very short about the wards and their treatment. Thank you.